So I'm just going to welcome. Good afternoon, welcome everybody in the live audience and on Zoom. If you're not sure yet whether you want to join us live, there's lunch here, so hop on over to the auditorium if you're close by. It is my great pleasure to welcome a special guest speaker today. We have Dr. Beatrice Goyla joining us from the Children's Hospital at Montefiore, Albert Einstein College of Medicine. As many of you might recall, Dr. Michael Cabana joined that group a few years ago as the chair of pediatrics. And through that connection, we have the honor of having Dr. Goyla joining us today. Dr. Goyla is a pediatric nephrologist, senior director of fellowship training at the Children's Hospital at Montefiore, and the fellowship director of pediatric nephrology. She's an internationally known expert in pediatric lupus nephritis and an investigator in NIH-funded research assessing molecular and clinical markers of progression to end-stage kidney disease. She has made many contributions to the field, including a lot of publications. She actually originally graduated from the Faculty of Medicine, University of Basel in Switzerland, and did her internship and residency in pediatrics at Jacobi Medical Center, and subsequently completed her fellowship in pediatric nephrology at Mount Sinai School of Medicine. She trained as an adult rheumatologist in Switzerland, and for reasons completely unclear to me, she disclosed that she did not like adults and not like Switzerland, and so moved to the US and started pediatric residency, all from scratch, doing this all over again. She was fascinated by the complexity of pathology that is involved in lupus and realized that only few nephrologists make lupus nephritis their area of expertise. And so that was the reason why she ended up with this specialty. And she's going to talk today about implementation of molecular diagnostics in the development of new therapeutics. And welcome her to the stage.
Thank you very much. I do not regret switching from internal medicine to pediatrics, and I also do not regret coming to the US, actually. So thank you for having me. I will like to say thank you for allowing Michael Cabana to grow here and be able to take on as a chair of pediatrics at our institution. He's really wonderful. And I'm very grateful to have him as my boss. I have just one disclosure, but other than that, let's move on to the topic. So today I would like briefly to speak about lupus and lupus nephritis. I would like to focus more on introducing you to the Accelerated Medicines Partnership and its institutions, investigators, and what the aims of this collaboration is, and ultimately some findings that we were able to publish through this collaboration. So systemic lupus erythematosus is a chronic autoimmune disorder that affects multiple organs. We estimate that there are about 1.5 million people in the US living with this condition. It affects every age, race, ethnic background, and socioeconomic status. But as you probably all know, women are more affected than men, and Black women are disproportionately more affected with more severe disease also than white women. Children and adolescents under the age of 18 make up about 20% of the lupus patients in the US. Also, we know that the vast majority of SLE patients in the US are government insured, and we have some statistics here. So it is important to know that this is a disease that affects not only minority populations, but also poor minority populations. Lupus nephritis is the kidney involvement of SLE and manifests as hematuria, proteinuria, low complements, hypertension, and impaired kidney function. About 40% of patients with lupus will develop lupus nephritis, and among children, about 60% will develop lupus nephritis. In African American and Hispanic or Latino women, the disease manifests earlier and is also more severe. A large meta-analysis actually demonstrated that lupus nephritis, once it is established as a diagnosis in SLE, has one of the highest mortality rates and significantly highest mortality rates, as well as increases significantly all-cause mortality risks, so cardiovascular disease and other risks. The overall prevalence of lupus nephritis is estimated at around 30 per 100,000. And again, the racial and ethnic distribution mirrors that of SLE that I mentioned on the previous slide. So the pathophysiology, as you all know from medical school, is extremely complex. Basically, whenever someone asks about a disease process that occurs in a patient, lupus can always be on the differential. So every medical student knows that lupus is a correct answer. And this is because this is an extremely complicated disease process that has some genetic predisposition. It is manifesting as autoreactive B and T cells, which lead to autoreactive and autoantibody production. It is triggered by various toxins, including UV lights, cells that undergo apoptosis and release cell components that serve as neoantigens, and microorganisms that have antigenic sequences that cross-react with human autoantigens. This graph here could be probably the topic of roughly 17 different grand rounds. And all we know is that it is extremely complex, and we really probably don't understand everything around it. The treatment of lupus nephritis focuses on controlling the autoimmune mediated pathophysiology. So it typically consists of heavy lifelong immunosuppression, which carries significant side effects such as infertility, risk of serious infections, reactivation of dormant viral infections, and let's not forget cosmetic side effects. The patients have a high pill burden. It is not unusual that patients with lupus nephritis will have to take around 18 pills a day. And think about it. These are women, young women in their 20s who want to go out and have their little purses, and they don't want to fill those little purses with pills. And the pills are actually the ones that remind the patients all the time of their disease. They may feel okay, but they have to take these pills, and that's what reminds them that they have lupus. And as a result of that, they hate the pills, and at the end of the day, that's what leads to a high rate of non-adherence. At the same time, being reminded as a young person that you're sick chronically and that you could die is associated with a very poor quality of life, and a high prevalence of depression with up to 50% in the patients, as well as anxiety in about a quarter of the patients. So lupus nephritis has many unmet needs, and I listed here a few just to see that, just to show you what the complexity is and how we want to address them with this accelerated medicines partnership. So I mentioned that 40% of SLE patients will have lupus nephritis, and in minority populations, this is even higher. Although we have intense research efforts, lupus has been a subject of research actually since the early 20th century, when the lupus rash was recognized that it is actually part of the systemic autoimmune disorder. But even so, there has been extremely slow development of new therapies. As a matter of fact, if we think about it, over the past 20 years, there were probably only 3 drugs at this point approved in the management of lupus. not necessarily lupus nephritis, that has seen only 2 drugs as of recent. In fact, the most 2 recent drugs were actually approved sorry, over the last 3 years. And end-stage kidney disease is a common complication. Patients with proliferative lupus nephritis have a 30% risk of developing end-stage kidney disease. And this is today with the treatments that we have today. We diagnose lupus by doing a kidney biopsy, and I'll go into this in more detail, but basically the only way for us to process the tissue is doing light microscopy, immunofluorescence, and electron microscopy. Now, this is probably the same level of tissue analysis that oncologists did in the 1950s for breast cancer. So we are really not utilizing the technology that exists nowadays that could actually help us define the disease much better in a given patient. And as a result of that, the tissue classification has relatively poor correlation with patient outcome. And then in addition to that, we have learned that tubular injury and tubular interstitial inflammation and interstitial fibrosis is associated with poorer outcomes. However, at the same time as we detect these findings, it's already too late. So we really have to identify the drivers of this tubular interstitial disease much earlier. And then in addition to that, we have really not understood the molecular mechanisms that drive the kidney disease. It's all that complicated diagram that I showed you, and we should be able to actually tease out the messages with current technology. So really identifying disease subsets of patients as well as therapeutic targets is an important challenge that we have to tackle. Pathogenic mechanisms that may be inferred from genetic studies currently have never resulted in actual therapies. And animal models are animal models. They are not humans, so biology is very different there. So this leads us to the Accelerating Medicines Partnership, or AMP. This is a collaboration that was launched in 2014, and it's between the NIH, academic institutions, nonprofit organizations, and biotech companies. And they have identified several disease areas that they initially tackled. Alzheimer's, autoimmune mediated diseases in general, autoimmune specifically, RA and lupus, gene therapies, metabolic disorders, Parkinson's, and schizophrenia. So obviously I will focus on the autoimmune aspect, particularly rheumatoid arthritis and lupus, and I will just focus at the end on lupus alone. This also included a plan for patients with psoriasis and Sjögren's. They budded off and went on a separate path, but basically RA and SLE continued to go through the protocols and the different stages of the management of this consortium. So the challenges that this consortium wants to address is the fact that we have the ability to gather a wealth of data from patients, from their tissue, from their urine, from the blood, but we haven't really gathered it in such a way that it makes it easier to actually identify targets and develop drugs. Some diseases, you may find biological insights where you think that the target is the right target to treat, and then the drugs ultimately fail. For a very rare disease, such as pediatric lupus nephritis, for example, or for genetically driven lupus nephritis. So there are patients that have defects in early complement pathway And those patients have very early onset lupus. Typically, when they're 2 or 3 years old, it runs in the family, and the patients have a very severe and difficult to treat disease. Having a gene therapy has really not even been tried yet. And developing a new drug, as you know, has a failure rate of 95% as we stand. And that comes with a cost of $1 billion. And the reason that's if they succeed, the reason why it is so costly is because a lot of the therapies that fail, unfortunately, fail in the later stages of development, not when it goes from animal to human for the most part. So really, we have to improve on that. And it shouldn't take 2 decades to develop a drug. So the aims are really to increase the efficiency of development of new therapies, improve prospects for success, and lower costs, because the faster you develop a drug, the cheaper it's going to be. And also increase the number and effectiveness of new target therapies, and obviously reduce, therefore, the rate of failures. And with that, also making these biotech companies more attractive for investors to want to support them. So the different phases so there are 3 research phases that we went through. Phase 0 was to basically develop and standardize the methods to analyze tissue, to collect tissue, to analyze tissue, to store it. So we use different types of means to prepare the tissue, to optimize it for long-term storage, as well as to ensure that we're still able to analyze the molecular markers that we would like to. The research phase 1 was geared towards identifying healthy controls that could be suitable to highlight the differences in disease versus in health. So we used a small number of patients that were very similar to each other, and that was to just achieve sufficient data to be able to show feasibility and then design the next phase. In the next phase, we enrolled over 200 lupus patients. And the goal here was to identify, first of all, what characterizes responders versus non-responders of disease or health or treatment, and ultimately to see who are the ones who are going to move to develop end-stage kidney disease versus not. So it was really, again, learning from the patients, but at a much more detailed and finite level than we do right now with light microscopy. So in other words, what we were trying to do was to deconstruct the disease by looking at what cells are involved in the disease process, what kind of genes do they express, and then establish what intracellular pathways are activated in what cells. And here, for example, we looked at T helper cells, fibroblasts, and then we also distinguished the responses in patients who do improve with therapy versus those who do not. And these tissue samples were always accompanied by blood and urine. We also got skin samples, actually, from these patients, because we wanted to see, is there a way of diagnosing these patients based on the molecular signatures without actually needing to do a biopsy. Kidney biopsies are fairly invasive. So we really want to try to avoid those. So developing biomarkers, targets of therapy, and molecular classification of the disease were some of the aims when we deconstructed the disease. So the whole picture is basically, we have this blur of a picture, which is representing basically that diagram that I showed you on the pathophysiology. We took apart every single aspect of it. We identified what every piece of this puzzle means. And then once we understand, we will put it back together. And we can do this at a personalized level for each individual patient that will ultimately tell us what therapy this patient is going to respond and what their chances are of avoiding dialysis altogether. So this is the stage of the disease reconstruction. We are currently still in this stage. So these are the investigators on the lupus network. Chaim Paderman was at Einstein when we started this. He moved to Israel in 2019. So that basically the shift in New York basically went to Jill Byon at NYU. So she's the main PI in this network. But these are all very well-known lupus experts that we were able to get together here. And the partners are these are the biotech companies, and these are the nonprofit organizations, as well as the different NIH institutes that are involved with funding this research. So these are the partners that ultimately provide the money. It was the group was divided into an administrative group, which is very important because when it comes to data management, tissue repository, all these things, this is extremely important to have a place where all the data is stored, which is accessible, and then make sure that that can inform the scientific group, and vice versa, the scientific group, as they gather new knowledge, they ultimately provide this data here. And the ultimate result of it is actually right here. This is public information. So all the information that is learned from this partnership becomes public knowledge. So anyone who wants to inquire about molecular pathways in a given patient with lupus and lupus nephritis, they can access it here and generate a hypothesis, and then actually apply to obtain tissue samples, for example, if they want, or blood samples or urine, to apply their proposals. So this is freely available to anyone. And just to remind you, this is just one area of disease. So if you're interested in schizophrenia or something else, you will find the same model there as well. So the goals are really to develop surrogate molecular markers that that really allow us to avoid invasive procedures such as a biopsy. We can understand lupus nephritis better and apply newer technology for better analysis of the tissue, and ultimately using single-cell RNA profiling that then becomes public data is, I think, a very valuable contribution to the science arena. So here is what we did in terms of the different research phases. I mentioned to you 0, 1, and 2. So in 0, we stuck to adult patients because, first of all, there's more of them, and second, it's easier to get their consent. The IRB also makes it easier to get consent. We used as healthy tissue at that time. It was the so-called healthy aspect of the kidney that has a tumor. And we biopsied the patients as clinically indicated, and that's how we used the tissue from these patients. In the research phase 1, we started making some changes that I think were significant because it allows us to truly differentiate between disease and health. And the other part we did is we lowered the age to 16 to allow some pediatric patients with some more severe disease to be included. The cutoff for a urine protein to creatinine ratio was 1, which was at that time the established cutoff on the adult side. On the pediatric side, we biopsy patients when their urine protein to creatinine ratio is over 0.5. So on the pediatric side, we are a little earlier on that. But this was standard of care back in those days, which is not that long ago, but a lot of things have changed as a consequence of this. And then what we did is actually rather than using tissue from tumor nephrectomies, because we're looking at such a detailed analysis of the tissue, we didn't think that using a tumor, a kidney that has a tumor is probably completely normal. So what I started really to do at our center, and then we did that in other centers, was basically taking a biopsy from a living donor for a kidney transplant. The beauty of it is, when the transplant occurs, because this is a planned surgery. The kidney is outside the patient when you biopsy them, or the donor, so it's no risk to the donor. And we were also able to take a little bit of skin from the incision site, which was also serving as the control for the patients. And that made it actually much easier to get tissue. And we also took blood and urine from the donors as well at the same time. So that made it a cleaner way of actually identifying what true pathological pathways occur in lupus patients. In the phase 2, we went even a little further, and we lowered the UPCR to 0.5, as we did in pediatrics, because in pediatrics we find severe disease in patients who have relatively low levels of protein in the urine. So the correlation is really not there. So we wanted to see, does this happen on the adult side as well? And this is just describing what we did. We also had follow-up samples of blood and urine at 3, 6, and 12 months after the biopsy and sample collection. And this is just visualizing what we did. We used kidney tissue. We divided it into single cell and basically ran fax analysis as well to cell sort. And we also used single cell RNA sequencing. In urine and blood, we mostly use proteomics. We also did some cell sorting, and we ran some biomarker analysis that came up as a result of the analysis of the single cell RNA-seq. And then obviously we utilized clinical and histologic data that was provided in the medical record, and all this was imputed, and then these were the analysis results that came out. We had an idea of what cells are active in kidney tissue. We clustered them according to gene expression. We were able to find cell subtypes that were more or less involved. We were able to divide them into cell populations, and with some pathway analysis, it allowed us to basically learn about the cellular interactions within the kidney between these different cell types. And that is where this reconstruction of the disease is occurring. So this resulted in a few publications. One of the things that I had mentioned to you earlier is that we are very concerned about doing kidney biopsies because it's invasive and there is an increased risk of bleeding. The issue was that we really needed 3 cores of tissue to be able to get enough for clinical diagnosis, as well as tissue for research. Our IRB did not allow us to do this. They only allowed 2 passes. So I was present at every biopsy, and I would analyze the tissue. This is what it looks like under 10 times magnification when you have a biopsy core. And I would divide it up and make sure there was enough tissue for analysis from a clinical perspective, as well as for our research. Other centers, though, were able to get 3 passes. And it turns out that 3 passes are actually no more risky than 2 passes. And this is important knowledge, because once you have other kidney diseases where you need to do to collect an extra core, this is a reference that can be given to the IRB, and so they don't have to worry so much about risk to the patient, because it's really not much higher than it is with 2 passes. And obviously, we as clinicians, when we see that there is a bleed, we will stop. We will not just go to 3 passes because we have to, right? So those patients will then be excluded from enrollment. And then the other question that came up was, what is the right time to biopsy? So we had this argument. On the adult side, they used the UPCR of 1. On the pediatric side, we used urine protein to creatinine ratio over 0.5. As we lowered in the phase 2 the cutoff, we were able to include more patients. And it turns out that on the adult side of the patients, they see the exact same findings that we see in pediatrics. There is a high incidence of patients that have severe class lupus nephritis, classes of lupus nephritis that includes class 3 and 4. And not only that, they already showed evidence of chronic damage, and that's significant. So you really, it really shows you that it is important to have tissue information early. So a patient with lupus nephritis, when they have new onset proteinuria, they need to be biopsied early. So then we went on to look at what the single cell RNA sequencing data showed us, and whether doing a skin biopsy could be a potential alternate to kidney biopsy. And it turns out that some of the pathways are activated in both skin and kidney. And that includes the type 1 interferon, as well as fibrotic pathways. And that is an important finding because it tells us we could potentially have a patient, if they flare, for example, they have known lupus nephritis, they flare and they may have also skin disease, probably that, assuming that interferon is activated here, that could be addressed, as we now have a therapy that suppresses interferon response. Just to be clear, the skin samples from the patients were actually from non-exposed, non-lesional skin. So basically, we took it from the butt of the patient because we didn't want any sun exposure there. So when we analyzed the tissue, we found that there were similar responses in the tubular cells. And this is where that tubular interstitial disease occurs and where the fibrosis occurs and where really the risk of progression to end-stage kidney disease occurs. So we had to, we actually were very intrigued to find that keratinocytes, so skin cells, show the exact same type of upregulation of interferon. And then in addition to that, we saw 5 fibrotic signatures, so TGF-beta and other profibrotic molecules that were ultimately associated with failure to respond to treatment. And that's not surprising, right? I mean, if a tissue becomes fibrotic, there won't be much response. But obviously, this is a relatively high or relatively early stage. So this is before fibrosis is actually evident on biopsy. So, so we have to really be careful when we see this type of molecular response, that this is a patient that is at high risk for resistant disease. And then we actually were also able to see a differential of expression of inflammation or inflammatory markers whether patients had the proliferative form, which is the more dangerous form of lupus nephritis, versus the membranous form. And so we actually, the other part that we wanted to do was really to see, can we find in the urine what we can find in the kidney? In other words, does the urine reflect the inflammation that occurs in the kidney? And one of the molecules that was picked was interleukin-16, because the single cell transcriptome was very high. And so, and it also gets excreted in the urine. And when we looked across the different platforms, we saw that IL-16 was always present, whether in the urine whether in the tissue or here at the immunohistochemistry level. So clearly, IL-16 could be a target of therapy. Right now, there are no IL-16 inhibitors that exist, but it could also serve as a non-invasive biomarker that could guide our treatment in the future. And then we wanted to know what type of responses. I mentioned to you there was a differential between the more benign form of lupus nephritis versus the more severe forms. So we actually looked at the single cell genomics expression at the cell level in patients with class 3, 4, and 5 lupus nephritis. We also used their urine and blood to confirm the findings. And basically, we found that there is kind of a gradient of immune response. So there are a lot more immunological markers upregulated in the severe classes of lupus nephritis versus in the more benign forms. And this method also allowed us to find which ones are the ones that are more upregulated. And that can ultimately be used to non-invasively diagnose patients with what class of lupus nephritis they have. And not only that, we can also identify what drives their disease and treat them accordingly. So I mentioned to you that an interferon inhibitor exists, and that is called anifrolumab, which was just approved, I believe, last year for systemic lupus erythematosus. In this cohort, they had patients that also had lupus nephritis, and these patients responded very nicely. So a phase 2 trial was run, and it showed that patients responded, but they needed an intensified regimen of this drug. So rather than just giving it every 300 milligrams every 4 weeks for 48 weeks, it needs to be given at the more rapid intervals at the beginning in the first 3 months, and then switch to every 4 weeks for the rest of the course. Now, this drug is approved, and once we have a better sense how much interferon response there is in a patient, which unfortunately on the clinical level right now, we can't get that answer right away. We are unable to do this, but hopefully in the near future, if we are able to identify patients that have an interferon-driven disease, we can actually treat these patients better. Today, in my practice, we see also adult patients. So we have started prescribing anifrolumab to patients who have very severe skin and kidney disease. We literally just got prior authorization for our first patient last month. So stay tuned. But I believe that this is going to be a drug that is now being tested in phase 3, actually, for lupus nephritis. I believe this is going to be a drug that's going to be added to the armamentarium. And then we also wanted to know what are the immune cells that are actually activated in lupus nephritis. So again, the same process. And what we did is we separated the immune cells specifically with FACS sorting and identified what types and subtypes of immune cells drive the disease. And basically that can be very helpful in designing more targeted therapies that address particular cell types rather than just broadly immunosuppressing patients. So the other part to it is also is that we found in urine sediment similar representation of immune cells that we found in the tissue of the kidneys. So in other words, we could potentially develop home testing to identify patients who are flaring, for example. So there is a group. This is Dr. Mohan is one of the drivers of this effort to identify new biomarkers that could allow patients to monitor their disease at home by doing at-home urine tests. So one of the things I just wanted to point out is that what this partnership has brought out is that there is an incredible power in systems biology. And I think you guys know more than me here at UCSF. You have some people really who are leaders in the field of computational analysis and driving the diagnosis of patients with various diseases. So we're using on the biology side all these samples, and then we input all this information. And without having this computational power of systems biology, we wouldn't be able to actually get this kind of information. It is data that can be leveraged to develop platforms that provide artificial intelligence decision support and clinical management tools that could allow us to diagnose patients much earlier, non-invasively, monitor them more tightly, and also obviously develop drugs and see how they respond to these drugs and know that they will respond based on their molecular biology. And this is not, we're not far from that. So Renalytics is a company that has developed a test that's called Kidney Intellects. It focuses on patients with diabetes. So as you know, diabetes is one of the leading causes of end-stage kidney disease in the US. And this test is basically a blood test that relies on several data points, including patient history and as well as some information about the patient's disease, but also has a proprietary signature of biomarkers that allows to develop a risk score per patient that predicts which patient is going to have a low, intermediate, or high risk for rapid progression. Typically, we're using albuminuria as a for risk stratification, but it turns out that there are diabetics who do not develop albuminuria, but they develop end-stage kidney disease. So this test is close to approval, if I'm not mistaken, and basically will change the way patients with diabetes are going to be treated. And hopefully down the line, this is going to decrease the number of patients ending up on dialysis. So my take-home messages are that basically kidney biopsies are safe in lupus nephritis patients, and we have to do them early. We have hopefully a way to avoid this invasive procedure in the future, as skin biopsies and urine samples may be good alternatives. And the combination of powerful technology with large patient numbers actually significantly accelerates the acquisition of new knowledge. And new biomarkers and targetable pathomechanisms can actually be discovered relatively rapidly. And as far as this partnership is concerned, I think it works. In the field of lupus alone, this partnership has actually resulted in 3 phase 3 trials at this point of drugs that we didn't even know the targets for 8 years ago. And recent advancement in AI, I'm hoping that we could actually get better clinical tools, because clearly that is one of the major unmet needs. And with that, I thank you for your attention.
Any questions? Give it a moment. Maybe I'll ask a question here. It still seems like a long time, 8 years, but I guess there's also all the organizational stuff of getting the network going. And I guess my question for you is, so one of the telling probably outcomes will be how these phase 3 trials will fare, right?
Yes.
Because if they fail, then you're back to
That is true.
beginning. And maybe I just missed it, but I'm not sure that I totally understood how this pathway would prevent failure of phase 3 failures more.
Yeah. So I think what the failures, what drove the failures in the past more was that we were focusing on animal data or on types of biomarkers that were not as specific for a given patient or in general for that patient population. And as a result of that, therapies were developed and they had to reach a certain stage in the human studies to actually show that whatever worked in animals didn't work. And I think that's where the highest failure rate came from. Here we took the animal out, right? We don't torture any mice anymore, which is good.
So really nice work showing the integration across from patient-derived data through complex scientific techniques. Do you have advice for people who are interested in approaches like this to other diseases, and how do the ball get rolling, and how do you sustain such a large and frankly expensive effort?
Yeah. So I think what led to this was ultimately just a historical failure of a lot of therapeutic developments in the space of lupus nephritis. And I'm sure there are multiple other disease spaces where the same occurs. The NIH comes out with statements every 5 years in terms of what their plans are for a certain disease, right? So the institutes that represent that disease should have that on their radar. So you need to have scientists that advocate for those unmet needs in that specific disease and show the importance of needing this kind of network. This didn't come out of the blue in 2000. This whole work was started in 2005 when I was not involved there, but when my mentor was involved in specifying what the unmet needs are in this disease population, and then showing recurrent efforts that did not result in improvements. We have not changed the time between onset of disease and onset of death in patients who have lupus nephritis. That time span hasn't budged a lot by maybe a few months with the standard of care that we have right now. So I think recognizing that is an important aspect, and I think that that is one of the major drivers. But the NIH listens. I mean, they have they know what they fund, right? And they know what applications come through, and they know that, as a result of that, academic institutions may be underfunded. They have the brain power, but they don't have the money to do all the research they want. And then you bring in the biotech side that has the money, but not necessarily the brain power. Mind you, some of these biotech companies have great R&D, but bringing them together and not looking as enemies of each other is probably not a bad idea. If you can't fight them, you work with them.
There's a question from the Zoom audience. Jim Petbury asked, can you use a machine learning approach to classify the patients based on omics, cyto-F, RNA sequencing, etc., to correlate with outcome?
Not today, and probably not tomorrow, but I think that is really the way to go. Right now, actually, there are efforts in using AI in reading pathology, so the biopsies, right? So there are now AI tools to identify areas of inflammation and so on that the human eye may not see, when the pathologist goes through the slide. I think we have to make proteomics, cell sorting and all these methods cheaper to allow us to actually get to integrate it into clinical practice and be able to apply AI or AI-driven technology. I think single cell RNA, so RNA sequencing has become a lot cheaper and a lot faster. over the past 5 years. Even while we were in the process of this collaboration, we switched platforms that from moving from being able to analyze 8 cells at a time to being able to analyze 50 cells at a time, and now it's 200 cells at a time. So this technology is moving very rapidly, and hopefully as the price tag drops, we will be able to also integrate it in clinical practice, because ultimately that's what we need to do, and that's the biggest challenge at this point.
Still exists, and even after getting all these data, it should be very objective, but it still goes into the paradigm of like what we know about different. I was wondering if you think that there is still significant bias in our approach to this, where we still need to maybe we still need to rely on like, okay, well, IL-16 seems to be the target.
Yeah. So the question is there still, even though this is a novel approach, is there still bias in analyzing tissue and blood and so on, and basically driving the answer with our own bias. So actually, I think this was a very very objective approach, relatively speaking, because we had no expectations. We didn't know what we will get. We actually weren't even sure if we were able to distinguish the different cells. We had to go through all these atlases of genes to identify what cell expresses what genes at baseline, what cell type, and to then identify what cell we're actually looking at. I think we were pretty agnostic about what we were expecting. We were happy to see the interferon response because we know about it. And yeah, obviously anyone who is in rheumatology would say, duh, I mean, we knew about interferon a long time ago. So what is new about that? What was new about it was which cells express it, actually. We always thought it was the immune cells, but this is renal tissue that expresses it, right? So it's almost like the tubular cells become members of the immune system. So that was the new part about it. And so this is why probably immunosuppression alone is not really the response, right? Because you're eliminating immunological cells, but you're not really addressing the immune function of what looks like resident renal cells. All right. Thank you. It was my pleasure.